Welcome to Medicine in Our Backyard. This series is presented by the Newport Beach Public Library Foundation. I am Adrienne Windsor. I'm very pleased to be a member of the Board of Directors of the foundation. How many of you are members? Wow, that's great. Next time, I want every hand up, because it's such an honor and privilege to be part of this foundation. We assist the library with its needs that are not fulfilled by the city. We get a wish list every year. We've done wonderful things. We not only have the Woody Lecture Series and the Library Live, we are doing this Medicine in Your Backyard. The chairs you are sitting on were provided by the foundation. If you've been to our media lab, that is a creation of the foundation. So we love to have your support, and I hope next time you will all be members. I want you to know that our next speaker in this series, Medicine in Your Backyard, is on January 28th, and the topic is biomarkers and drug repositioning for neurodegenerative diseases. Did you like that? Did I do a good job? Our speaker will be Dr. Howard Federer. I'd also like to thank Mike and Polly Smith for their generous support of this series. They were the inspiration behind it. It was their idea that this library could come together with UCI and provide this significant opportunity for us to learn from those who are essentially right here in our backyard. Now tonight, our session will end with a Q&A session. We will have questions for about 15 minutes. I'm going to ask our speaker to repeat the questions because we are taping this presentation. If you haven't turned off your cell phone, and I just checked to see if I did, please do that right now. And now I'm pleased to introduce our fabulous speaker, Dr. Shaista Malik. When you look at her, you will not believe all that she has accomplished in order to be in front of this room. She looks so beautiful and young and vivacious, and yet she did her undergraduate education at Stanford. Then she earned a master's in public health at UCLA before entering UC Irvine, where she completed medical school and her residency in medicine and a fellowship in cardiology. During her fellowship, she obtained her PhD in health services at UCLA's School of Public Health. She is known for her excellent clinical care and has a reputation as a caring mentor to her students. Dr. Malik is also nationally recognized for her research. She was awarded the prestigious National Institute of Health's NIH grant to study genetics and biomarkers in preventive cardiology. She is a director of the Susan Samueli Integrative Health Institute, as well as the medical director of the Preventive Cardiology, Cardiac Rehab, and Women's Heart Disease programs at UCI. I see we have a lot of women in this audience tonight. You know, they always tell us we don't know our symptoms when we are having a heart attack. So I hope Dr. Malik can help us with that. She is going to be speaking tonight on activating resiliency against stress, inflammation, and heart disease. Please join me in welcoming Dr. Malik.
Thank you so much for that very kind introduction, and it's just such a pleasure and an honor to be a speaker in this series. I had a chance a couple of years ago to be on a panel discussion, and this time I get a whole hour for myself. So this is a really interesting topic, and we're going to be talking about it using an integrative medicine approach. Can everyone hear me in the back? Great. So before we start, I'll give you a framework of what integrative medicine is. It really is a patient-centered approach, and it takes into account mind, body, and spirit. Now, as a conventionally trained cardiologist, I was trained to focus on advanced diagnostic testing, biomarkers, making sure that I understood symptoms in men and women. But we never really get taught some of the things that are part of integrative medicine, including the role of nutrition, looking at root causes like genetics, and then, of course, the huge role of the mind on things like heart disease. And although there's robust research showing that these two are connected, they don't really come into play in the clinical paradigm. And why is that? Well, part of it is, what our healthcare system is built on and what our reimbursements are built on. And the history of that, as you all know, is fee for service. So as a result, we don't focus on prevention like they do in other countries. And the focus is always on procedures, on getting a diagnosis when someone already has established clinical disease. So integrative medicine really appealed to me because when I became a cardiologist, I would see people returning, 6 months later, needing another procedure. And so I wanted to see, how do we prevent the next procedure or the first procedure at all? And when I looked at those factors, that's what appealed to me about integrative medicine. So this is a little busy slide. This is called the integrative medicine or functional medicine tree. And if you think of it, don't worry about all the writing there, but just think of sort of health and wellness kind of like a tree. And you have the big trunk, and you have the tree with the canopy, and you can think of these big branches as different specialties or different organ systems like cardiology, pulmonology, oncology, and that's what you see up there. And that's really driven, the organ system diagnosis is driven by a Western medicine paradigm. And, with the scientific revolution, which was a great thing because it resulted in our ability to find antibiotics and fight infections and not have, a third of children die under the age of 5 from infection. So it was a great thing. But that scientific revolution taught us to look and focus on one biochemical pathway at a time. And that kind of paradigm led to from one pathway to one organ to one specialty. And so what now integrative medicine tries to do is to go down to the root causes and look at things like sleep, exercise, nutrition, stress, genetics, because we know that those are at the root of all these different disease points that you see on top of the canopy. We're also coming into the age of precision medicine and understanding how genetics and how those genes get turned on and off, so epigenetics. That's an area of research that I do. And when you start looking at things at a systems level or a systems biology level, you start to see all these different connections. And there are, for all these diseases, there are very common nodes that you can study now biochemically. So we're coming into the age of having the computing power to look at multiple variables instead of just that one biochemical pathway at a time. We can look at multiple biochemical pathways and say, this is what's at play. This allows us now really to focus on health versus extending life. What do I mean by that? Well, it's about, and this is becoming a very common phrase, the focus on lifespan versus health span. And so again, our traditional model has looked at extending the lifespan. We're very good, for example, in cardiovascular disease, when someone comes in with a heart attack and they've come within the right window of time, in 2018, we can open a blocked artery, re-infuse the damaged muscle, and bring cardiac function back to normal. And by the time someone's discharged out of the hospital, it's as if they've never had a heart attack. And the same is true for diseases like cancer. They're becoming chronic diseases. But a lot of times we're extending lifespan because, as I said before, 6 months later the patient comes back with chest pain, or symptoms continue. And so this is sort of the model. We have health, we develop symptoms that leads to a diagnosis, we do a procedure. A lot of times we get side effects because when you're looking at just one biochemical pathway, you don't see what's happening in the other pathways when you give a treatment. And so that side effect leads to additional diagnosis, sometimes more procedures, more medication, surgery, and you get disease progression. Once the disease gets started, you have to really focus very hard to stop it from progressing. And so now the focus in integrative and preventive medicine is to look at underlying causes. And as you start to address those root causes, then you can start to prevent and reverse chronic disease. And Dean Ornish, back in the 1980s, showed that you could reverse heart disease. He did angiograms on patients before and after putting them on a vegetarian diet. And he showed just with diet alone, people didn't believe his findings. Just on diet alone, he was able to show that the plaque could reverse. Shoot ahead, to current research, we now have CT angiograms where we can see inside the vessel wall, and you can see when you change people's cholesterol levels, you can actually shrink plaque. So you can reverse disease. So I'm going to focus now on heart disease, and we're going to talk about how we usually diagnose heart disease. So back in the 60s, we started to assess what are risk factors, and the Framingham Heart Study showed us that certain risk factors, and this was a term coined by the Framingham Heart Study back in the 60s, we started following blood pressure and whether someone had diabetes or not, high cholesterol or not, or a smoker. I mean, it wasn't too long ago where people didn't believe there was a link between smoking and heart disease. And so the Framingham Heart Study showed us that it was. And so even now, we use these risk factors. So when you come in to a cardiologist's office and you're having symptoms like chest pain or atypical symptoms in women like shortness of breath, we calculate your score and then decide, should we go straight to a stress test? Do we need more information? And sometimes, we have enough information to even recommend going straight to an angiogram, especially if you come in urgently. And the conventional treatment in heart disease is statins. We had the American Heart Association in 2013 publish very strict guidelines on who needed statins, and it turns out 2/3 of the adult population, according to those guidelines, needed statins. And it decreases heart disease by anywhere from 30 to 50%, the use of statins. Aspirin is another therapy, and it decreases the risk for a stroke or a heart attack by 20%. Then your blood pressure medications like ACE inhibitors, angiotensin receptor blockers, decrease heart disease by another 20 to 30%. And of course, if you're at a stage where the blockage is 70% or more, then opening up the artery is considered to be the correct treatment. And again, this treatment saves lives, undoubtedly. However, we still have heart disease as the #1 killer of both men and women. And so we treat heart disease based on symptoms, right? We don't really have a screening test for heart disease like we do, for instance, for colon cancer. So for colon cancer, you can get a colonoscopy, and if there's polyps, you can get treatment and surveillance based on that. Well, if you think about it, there's nothing like that for heart disease. The first time that you need a stress test is when you develop symptoms. But here's the problem. 50% of heart attacks happen in someone without prior symptoms. So, and then majority of them will have a normal cholesterol. So that's sort of the conundrum in cardiology. Like if some of the basic conventional ways of looking at risk factors fail us, what are we to do? And this is just another slide. I don't know how many of you remember Tim Russert. He was a newscaster, and he was on a statin. His LDL cholesterol was 104, and it was actually, that's the mean. His was actually below 100. It was near 70. And he had done a treadmill stress test, passed it, and then had the heart attack the next day. So why is there this conundrum? Why is there this disconnect between what we think are risk factors and then who goes on to get a heart attack? It's because the two curves overlap a lot. And so here's total cholesterol. Those that did not have coronary artery disease, it's a bell-shaped curve for total cholesterol. And then those who do have coronary artery disease, there's an overlap of about 20%, where you can have a normal cholesterol and still develop heart disease. So we are, as I spoke about a little earlier, we are in the age of genetics and trying to understand why in those patients where there's this disconnect between what we know conventionally and what actually happens, how do we use this more advanced information like biomarkers, genetics, and imaging markers to do a better job? So this talk, we're also going to bring in the mind part of the mind-body, and that's stress. So stress has been this amorphous concept, and one of the reasons your physician doesn't ask you about stress is because we don't really have good measures of what's stress for one person versus stress for another person. So stress turns out to be very subjective. And we'll talk about a few studies at the very end that deal with the stress response. But we know that whatever is stressful to someone, it actually results in quite a few visits to healthcare providers. And there's a big link with heart attacks and stress. So we were talking about blockage, and the blockage actually, thankfully, is inside the artery wall. So the blockage is shielded from blood flow with this lining called the endothelium. But as that plaque gets bigger and bigger, this lining that's protecting it from the blood flow gets thinner. And especially if there's inflammation, that lining becomes more prone to rupture. When this lining in particular ruptures, a plaque can go from being 50% blocked to 100% blocked. 100% blockage is when you have a heart attack, right? There's no blood flow. So 99%, you can have blockages up to 99% and not have a heart attack. And so we know that stress causes inflammation, and it can lead, and it actually also increases the clotting, especially in women. We know that acute events like earthquakes increase heart attacks in the population. In fact, the Los Angeles coroner reported a 5-fold increase in fatal heart attacks on the day of the Northridge earthquake. So we know, again, stress, very subjective, but when the whole population is subjected to something that we can all agree is stressful, if you have underlying disease, you can be vulnerable and end up with a heart attack. So how do we go about now taking in some of these things we know about the mind-body, about how we can, in 2018, personalize and figure out whether we're at risk for heart disease? So clinical disease means that you have symptoms. We're talking about subclinical disease, where you have plaque, in the case of heart disease, but no symptoms yet. And so one of the ways that we can assess heart disease, remember, there really isn't a screening test for heart disease that insurance pays for. But it turns out there's about 30 years of research on a screening test related to doing x-rays of the heart or CT scans of the heart. And it turns out that we can determine, based on the calcium in the arteries, because calcium co-locates with plaque. So it's a footprint of plaque. And we can determine what someone's arterial age is versus their biologic age. And that, we've done studies to show that if we now take statin therapy or aspirin therapy and personalize it based on how much calcium someone has, we do a lot better in preventing a heart attack or stroke. And for instance, we can target how low the LDL cholesterol needs to be, right? The 2013 American Heart Association guidelines kind of took away those treatment targets from us because there are really no randomized controlled trials treating people with statins and treating them to certain levels. And so, in lieu of those guidelines, assessing someone's calcium score can give us a hint about how low to drive that LDL cholesterol. Then we were talking about women versus men. So in terms of personalization, gender, sex, biologic sex matters. Women are protected from heart disease because of the effects of estrogen until they hit menopause, and then they quickly catch up to men. And their symptoms differ because it turns out that women probably lay plaque down differently. Estrogen makes the arteries more distensible. So the arteries are not as stiff, and when they do get plaque, it gets laid down diffusely versus in one spot. And that's a new finding. It needs to be replicated in larger studies, but an NIH-funded study called the WISE study that looked specifically at women and heart disease found that to be a difference. So the plaque tends to be in the smaller arteries and in the very small arteries called microvascular arteries. Both men and women can have heart disease in the very small arteries, but it turns out that women, when it comes to microvascular disease, it's mostly women that have that kind of disease. There are novel risk factors. So now you can get labs done that have markers for inflammation, that have other markers like homocysteine or fasting insulin that can give us a clue as to the risk of that plaque getting inflamed and being more vulnerable to rupture. So we talked about a little bit about diagnosis. We're going to talk in the presentation about treatment as well. Nutrition and exercise are foundational. If you could put those into a pill, it would be considered, the best pill ever invented, because it would reduce not just heart disease, but all chronic disease to the level that no other therapy that we have currently can. Up to 20% of the population really can't take statins. So that's not really, when you read the package insert for a statin, they report 2%. But what they're reporting is those people who've completed a clinical trial. So what happens in a clinical trial? Has anyone ever participated in one? Great. So there's a phase called the run-in phase. And in the run-in phase, you're either put into placebo or the treatment. And if you fail, meaning you develop a side effect, in the run-in phase, you don't go on to the actual trial. And so as a result, a lot of people who would have statin intolerance were not studied. And that's not unique to statins. That's true of any drug that's studied with a run-in phase. And so in my practice, when someone comes in saying my upper arms are aching, or my back aches, or my thighs ache after starting a statin, I believe them, because 20% of people have that. Now we can test for a gene that shows us whether you have a defective transporter in the liver that allows the statin to stay in the system longer. And so a lot of times we can play around depending on what we see on your genetic profile and still be able to have you take a statin. But, in those who are statin intolerant, sometimes they only need statins a few times a week or alternate days, because it's just hanging in their system longer because of that defective liver transporter. There are some who can't take a statin at all, even in the alternate dosing of a few times a week. And then there's a role for nutraceuticals, including certain supplements that have evidence base for reducing cholesterol. Treatment from an integrative approach also includes stress mitigation, or how do we moderate and mitigate the effects of stress. And this is really where, an integrative practice can have mindfulness classes, yoga, tai chi, meditation. Actually, transcendental meditation is an integrative therapy that the American Heart Association recognizes. In the guidelines for reducing high blood pressure, one of the level 1 therapies that's recommended is transcendental meditation, but most cardiologists don't remember those guidelines. And so, the other issue is, even if you recommend that to a patient, how do you, help them? You can't write a prescription for it. How do you help them get to a place where they can understand how to meditate? But there are now some meditation studios in the community, and they are handing out prescriptions for meditation. We will talk a little bit about targeted acupuncture. We have an NIH trial starting on chelation therapy. The environmental toxins, and I forgot to mention this as a root cause. We are exposed to many more toxins from the environment than ever before in history. And a lot of these toxins create inflammation, create factors that set us up for disease, like insulin resistance. So we currently are doing a chelation therapy to remove some toxins at our center. And then I won't have time to talk about it, but we also, part of the integrative medicine wheelhouse is talking about hormone replacement. Because as we age and lose sex steroid hormones, there are some effects, cardiovascular effects, that are detrimental. So the timeline for heart disease is actually quite long, and our hearts are pretty forgiving. So we start forming plaque around the age of 20 in the big artery of the body, the aorta. And over time, how quickly we progress, and these little white spots are the calcium. So this is what, over time, the inflammation leaves calcium as a footprint. And that's what we can measure on an X-ray or CT of the heart. So this is an indicator then of aging, because it kind of is parallel to that timeline I was showing you. And this is what a CT scan of your heart looks like. And this, between the two ventricles, this little really bright spot is calcium. This part's the heart, the black is the lungs. And this other white spot is your spine. So you can see the calcium there and there match. So we can calculate a calcium score, or we can look at the thickness of the artery, because the plaque forms between the different layers. So we can measure that thickness between the layers of the neck arteries and give an idea of whether there is plaque and how far along. And this is, an example of, again, a CT scan. This is normal arteries. You can see that they're the same color as the rest of the heart. This is mild calcification. This is severe, and this is extensive when the whole artery is essentially calcified. And so we have now enough data from these calcium scores to be able to say what calcium score to expect at what age. And then that helps us figure out what the arterial age of a given patient is. And then it turns out that this calcium score, and we showed this in a study of 6,000 patients, that the calcium score is actually more powerful than traditional risk factors, right? Diabetes is supposed to be a traditional risk factor. So if you have diabetes, your risk for heart disease is supposed to be much higher than someone who doesn't. However, now if you stratify that by calcium score, so if you have diabetes, but your calcium score is 0, which was true in 30% of those with diabetes, the risk for heart disease is the same as not having diabetes and a calcium score of 0. So it was the calcium score that was the differentiator, and not whether there was diabetes. And we repeated this study and we followed these patients out to 10 years, and again showed that if you have a calcium score of 0, and there are individuals, even at the age of 70, 80, who have a calcium score of 0. So it's not a natural aging process. Then your risk for heart disease is very minimal, even if you've had diabetes for 10 years. And so you can go online if you get a calcium score, and you can go to this study that I'm a part of, the MESA study, the multi-ethnic study of atherosclerosis, and you can plug in your calcium score, your age, your gender, and you can plug in some of the risk factors, and it'll tell you what your arterial age is. So this patient, female, 46, with a calcium score of 10, which is quite mild, has an arterial age of 56. And here, a 50-year-old male who has a calcium score of 100, his arterial age is 73. But it turns out that calcium isn't the full story, because as you start to improve your risk factors, the calcium score can increase. But over time, the calcium becomes dense. And so then it actually becomes more difficult to rupture that plaque. And so in our new study, we're actually showing that having dense calcification can be protective compared to having a soft plaque that can rupture. So that's the caveat about calcium score. In the future, not only are we going to be able to see calcium, but we'll be able to see inflammation, because it turns out it's the inflammation that's the bad actor here. And a lot of things that we talk about, all the risk factors, stress, diabetes, are mediated through inflammatory markers. So this is a scan now, and the blue is actually inflammation. So coming back to the topic, the mind-body connection, again, it's been this amorphous thing. Integrative medicine's been kind of this, outside specialty that not a lot of conventional physicians ascribe to, because it is so fuzzy. Like, how do you make some of this concrete? Coming back to sort of the new tools, both in imaging and biomarkers, I'll show you a quick example from a study done at Mount Sinai in New York. So what is the connection between stress and balancing the autonomic nervous system? So you have the two types of nervous systems. One is kind of on autopilot, and the other one's conscious, right? I'm speaking because I have through a conscious mechanism. But when you breathe, when you have reflexes, that's autonomic. And that autonomic nervous system has two parts, sympathetic and parasympathetic. Sympathetic's the brake, is the accelerator. Parasympathetic is the brake. So sympathetic is your fight or flight, and parasympathetic is your rest and relax. So what chronic stress does is put your body into chronic sympathetic mode. And our bodies were not designed for that. We were designed to have an acute stress response, run away from that saber-toothed tiger and be able to increase our heart rate, our blood pressure, and keep up with that physical demand. But then when that acute stress went away, our bodies would go back into rest and relax. But in societies now, many of us are under constant stress. And so what happens to the body when it's under constant sympathetic system? Well, part of it is also increased inflammation and increased inflammatory markers. Why do you need increased inflammatory markers? Well, they allow you to clot better, for instance. So if you got, if the saber-toothed tiger almost caught up to you and swiped at you and you bled a little bit, you want to be able to clot quickly. So some of those markers that are associated with stress are protective for acute stress. The circadian rhythm is designed for us to be fluctuating between these two states. Our bodies have the lowest temperature right before we wake up. Around 6:45 a.m., we have the sharpest rise in blood pressure, and that's why a lot of heart attacks can happen in the morning. We have the highest alertness around 10 a.m., and this is for like the majority. Some people's circadian rhythms are different. We have, melatonin secretion start, and then the bowel movements get suppressed right before we sleep. So the body has a rhythm that's based on whether, we're in stress or whether we have acute stress or not. They're not really designed for chronic stress. And one of the markers is that our blood pressure around the same time that melatonin starts to get secreted, our blood pressure drops. So if you were to take your blood pressure in the morning and then in the evening, a really quick marker, and we use this in research all the time, is whether you're a dipper or not. So it's called dipping, and it should be your nighttime blood pressure should be 10 to 15% lower than daytime. And if you don't dip, that means you're under chronic stress, that sympathetic system is activated all day, and you're not going into rest and relax. And that's kind of a quick way. It doesn't always mean that, so I have to give you a little caveat. When we use this in research, we do measurements over several months and do averages to diagnose this. I'm going to skip this. So talking about the new tools, this is the Mount Sinai study. They took about 300 patients, and they did a PET CT of the brain, the bone marrow, and the heart. So right here in the brain, there's these almond-shaped structures called the amygdala, and that turns out to be the center in the brain for fear and stress, anxiety. They took images of the aorta. So this bright structure right here is the heart, and this structure where you see the little red, those are the inflammatory markers. That's the big artery of our body called the aorta. They didn't do coronary arteries because they're really small. Their coronary arteries are 2 millimeter to 4 millimeter, and they just wanted to do a bigger slice. They also looked at the spine and looked at bone marrow activity. So why did they do this? They actually did this in sequence. They looked at the brain first. They gave someone a questionnaire on how much stress they were perceiving in their environment. And it turns out that perceived stress is linked to that amygdala, that brain center of fear and stress, lighting up. They then looked at the spine, and they saw in people in whom the stress center was activated, the bone marrow gets activated to produce inflammatory cells. And those are the white blood cells. And then they saw sequentially that the artery started to light up with the inflammatory markers. And then they decided to follow up patients for 12 to 18 months. And these were patients who already had heart disease, and to see if they would have another event. And so it turns out that in the patient where the amygdala lit up, here's a patient with a huge stress response, the bone marrow lighting up, the aorta lighting up. Unfortunately, this patient went on to develop a stroke. So it was tied not only to these parts of the body lighting up, but tied to actually having an event in that follow-up period. They are now trying to study in patients where the amygdala lit up and the bone marrow lit up and the artery lit up, but didn't have an event. What's unique about them? Because there are individuals like that too. So I don't want to leave you with, stress being so bad. It is, but there's resiliency. So I'm going to skip some of this and get to the resiliency part, because I really don't want you guys to leave here without knowing there's resiliency. This is just, some novel labs that we can do in the office. They're available to many doctors. A lot of my colleagues use this. And you can look at inflammatory markers. So even if your cholesterol LDL is 72, you can see on this test, this patient's at high risk because of inflammatory markers. So this is like that patient who, it doesn't matter where the cholesterol is. This is like a Tim Russert. They still have inflammation. You haven't taken care of some of these things that could result in a heart attack. So meditation, it's an excellent therapy. That amygdala, that fear center, it can really turn it off. And this is a study out of Harvard. It increases attentional network. And this was actually a breakthrough study because prior to this, it was thought you had to be a Tibetan monk to kind of get changes in the brain like this. This is over an 8-week course called the Mindfulness-Based Stress Reduction course, so MBSR. And we have that course at our center. It's a University of Massachusetts based course, you have class 3 hours a week, 6-hour retreat, can result in changes in your brain, including turning off that amygdala. Tai Chi can do this similar things. I won't go over acupuncture, but we are studying cardiovascular disease and acupuncture, and we're trying to, again, create an algorithm so there's not a lot of variation, and you can actually write a prescription and say these are the points that need to be activated. Once a week treatment for 30 minutes over 8 weeks, followed by once a month, resulted in an 8-point drop in blood pressure. So just once a week for 8 weeks, then once a month. Fish oil, I know there's been a lot of controversy, but it's very anti-inflammatory. And in the studies that have been done rigorously with the right dosages, it's been shown to be protective. And the recent American Heart Association meeting found a fish oil that's EPA only to reduce events by 20 to 30%. And we can now actually assess whether you're getting enough fish oil. And we know from research studies what that index needs to be at. So we have goals. When we give supplements and nutraceuticals, we now finally have the lab values to match to see whether we're repleting and replacing correctly. There are adaptogenic herbs that I sometimes use. If you are in a high stress state, one of the markers related to stress is cortisol. It's a hormone released by the adrenal glands. And there are certain herbs like rhodiola that increase the ability of the body of handling stress. So they're called adaptogenic. They actually work when you have a high stress state, and they can improve anxiety and stress. But here's the very interesting part. Stress is a factor if you think it's a factor. So I've done you guys all a disservice. Thinking stress is bad for you is what's really bad for you. In a U.S. adult national survey of almost 30,000 individuals, they were asked about the level of stress and effect of health, and then they followed the study participants for 8 years to see what happened. So this was the question they asked. In the past year, and I won't have you guys raise your hand, but just remember your answer in your mind. Have you experienced A, no stress, B, relatively little stress, C, moderate amount of stress, or D, a lot of stress? And then remember your answer to this question also. In the past year, how much effect has stress had on your health? None, B is hardly any, C is some, and D is a lot. And so when you put those two questions together, these are the results. It turns out that it's not about how much stress you've had. It's about whether you think it's had an effect on your health. Or maybe it's because you're living healthy and that stress isn't affecting your health. So, that's we don't know which way it was. But it turns out that even people who have a lot of stress, if they said it had no effect or little to moderate effect, their risk of death was the same as having no stress. So perception's everything. You're on a roller coaster or... The last thing about resiliency, social connection has a huge factor. The fact that you all belong to this organization or attend this lecture series is actually protective, and I'll show you why. In this survey of 846 adults, they tracked stressful life events over 12 months, like serious illness, job loss, financial difficulties, death in a family. And they also asked whether they were helping others. So non-paid activity, like taking care of the grandkids, doing housework, running errands, or doing shopping for someone else. And so if you had one of those stressful life events, this is actually mortality. This is a hard outcome, like risk of death. Those who had high stress had more risk. Okay, this is survival, so less survival. And the dark line is low stress, the gray line is high stress. But now look at this. If you helped others, if you had social connection, and you were giving of yourself, you mitigated high stress. And so we're now into the 21st century, and medicine's changing. We're starting to understand that it's not just that one pathway, it's actually a metabolic network. It's not one disease, it's a disease network, and it's perhaps tied to our social network. And I'll end at that because I want to be able to get questions and answers. Okay. So thank you.
Thank you very much. Please raise your hands and we'll let Dr. Malik acknowledge you. If you'd please repeat their questions.
Sure. Lady in blue right there. So the guidelines from the U.S. Preventive Task Force have withdrawn that recommendation for baby aspirin. Because there is risk of bleeding. So I think having a conversation with your physician, trying to talk about what disease you're trying to prevent, aspirin is protective for colorectal cancer, for heart disease, for stroke. So I do use it in certain patients, but I look for evidence of inflammation. I look to see a very cheap genetics test is family history. Is there family history of certain chronic diseases if we're not going to do genetic testing? And then what their coronary calcium score is. If you have a coronary calcium score of 0, you have more risk for bleeding with taking aspirin than benefit. So it's personalized. Yes, so in terms of the differences, do you mean biological differences between a 20-year-old and an 80-year-old? So, once we, I guess with age, when it comes to stress, I think we improve in our stress and resiliency. Some of the ages where you have the hardest time with stress is adolescence and midlife. And after that, at least that's what the studies say, you guys can tell me differently, after about the age of 50, stress levels at a population level start to decrease because we become more resilient and wise, and that's been shown. As far as chronic disease, I do think that more and more scientists believe that aging is a process that eventually will have the tools to slow down, if not stop. And it's at a cellular level, our cells become, it's called senescence. They stop working like they should. And we are learning possibly of new ways of getting those cells to start functioning normally again. So, sorry, that was a broad question. I don't know if I answered that. So you're asking if the calcium test I'm referring to is a heart scan? Yes. So, a lot of times it's called a cardiac scan, and there's 2 types. You can get one without any contrast, so no IV. But if you want to look to see how much blockage there is under that calcium, then that's called a CT angiogram. So there's 2 types of heart scans. But the reason I initially said there's no screening test for heart disease is because insurance doesn't pay for it. So that's a great question. We have hints of some of this from CT scans. So the study that Dean Ornish did was a regular angiogram. And in a regular angiogram, you can't see inside the artery wall, you can't see the plaque. You just see whether the artery is open or, or how much it's closed. So that lining of the artery, the endothelium, is very forgiving. You can have calcified arteries, but if you can fix the lining function, it can behave as though you don't have blockage. And that's why people like Caldwell Esselstyn, he's at the Cleveland Clinic. He was Bill Clinton's physician who put him on the vegan diet. If you go, I believe that depending on the stage of disease, you have to get stricter and stricter and stricter. If you're at the stage where you have, diffuse severe calcium, you have to start being very restrictive with animal fat, because the cell lining, that endothelium, doesn't function well. It doesn't expand with demand if there's saturated fat around. So that's my theory. But if you try to put together the data from people showing angiograms that revert to normal in 6 months, well, plaque took 30 years to get there, and there's calcium. It doesn't really come out. It's that the lining gets healthy, and now your artery expands properly, even though there's plaque underlying there. Yeah. So that's a great question. Your question was, and I'm sorry, I'm repeating the question for the recording. I don't think I did that for the first one. It's about calcium supplements and whether, when you, in the setting of osteoporosis, osteopenia, should you be taking calcium supplements? The data on that is unclear. So what the data do agree on is the calcium supplement dose of 2 grams or 2,000 milligrams is too much. Probably needs to be closer to 1,000, if not 500 milligrams. And especially if you look at the data on postmenopausal women and calcium supplements, it shows that it does lead to increased calcium on the aortic valve and increased calcium in the heart. But that's just the surface. I think what's underlying that, and it's a biological process that has not been taken into account, is what your body does when it absorbs calcium. It has a choice to put it into the bone or to put it into soft tissue. And that system is regulated by a protein. It's called the matrix GLA protein that's regulated by vitamin K2. So if you are taking calcium, or vitamin D, because vitamin D increases your calcium absorption from your diet by 50%. If you are doing that, you must take vitamin K2 alongside with it. You need that cofactor for the body to know where to put that calcium. Otherwise, it could be putting it into soft tissue, not just the arteries, but your ligaments and joints. Yes.
Challenge you to repeat that question.
Yes, sorry, I should have taken notes. So, you asked about several things, including fish intake, alcohol intake, sex, and I'm sorry, let's go back. Oh, circadian rhythm, and if there's a good time to be taking your medications. Did I get those? Those were the 4 things, right? So let's start with circadian rhythm and taking medications. There's absolutely a time when certain medications work better. And we know that. There are studies that show taking your blood pressure medication at night makes them work better. And if you recall that chart on circadian rhythm, your blood pressure goes up right before you wake up. So you blunt that cortisol secretion, resulting in increased blood pressure in the morning, that spike, by taking the blood pressure medicine at night. Interestingly, and sometimes things are hypothetical, but then when you study them, they don't turn out to be true. So the same hypothesis was used for aspirin, whether you should take your aspirin at night, because your platelets get more sticky during the night. And so you have an increased propensity to clot. But in that study, taking aspirin at night didn't help. it work better. So there's probably another biological pathway that we don't, we haven't studied or don't know about. There are some integrative oncologists that time chemotherapy based on the circadian rhythm. And so, again, they've published small studies. There hasn't been a large study done for that. So that area, and we have some circadian rhythm researchers at UCI, that area is one that's going to blossom. And we're all trying to figure out, how does our body and its response to light and night and day change things. The second question was about fish oil, and is it better to eat fish than take fish oil supplements? It is better to eat fish. In all the studies, it shows that it's, you get better outcomes, and you have lower mortality if you actually eat the fish, because there are cofactors. Not only are you getting fish oil, but there's also vitamin D and other nutrients that help the fish oil absorb. And a lot of times you give people fish oil supplements and they don't absorb it right. And so you then have to keep giving higher dosages. So I always say fish first, but then test your blood to see if you're getting the right amount, and then supplement. And if you're a vegan, there are vegan fish oils, omega-3s, made from algae. They don't have as high a dose, but the highest dose is called Bloom. And, it's better for our oceans that we're not, harvesting all these fish for fish oil supplements. So in terms of sustainability for the environment, it's also better to eat farmed fish or sustainable fish. Yes. Oh, I forgot two of your questions. Moderate alcohol depends on your genetics. If you have a certain gene called ApoE4, moderate alcohol is not protective, at least in the small studies that have been done. And then hormone replacement, sex is a stress mitigator, maybe, for some people, versus stress inducing. So I don't really know the answer to that. Sorry. Yes.
Organic foods versus the foods that we've been eating that are supposed to have so many pesticides in them. Is there a...
So there was just a study that came out, I think, last week or the week before, that actually showed that mortality decreased by 20%. I mean, it was a really big number for eating organic versus not. But they didn't break down, the different reasons. Yes, in the class.
How often do cardiologists look at heart rate variability, either as diagnostic or a form of treatment to biofeedback?
Great question. So the question was, how often do cardiologists look at heart rate variability for treatment or diagnosis? The answer is never. And that's really sad, given all the thousands of papers probably on heart rate variability and what it means for the stress response and for cardiovascular events. The reason is, when we look at, in research, things kind of accumulated over a population, sometimes it's hard to then translate it back to a patient. And you also asked about biofeedback. So heart rate variability, we think we have regular heartbeats, but it actually turns out that they're a little irregular. And it's a great way to know whether you have enough parasympathetic nervous system activation, so the rest and relax, because that's the brake. The vagus nerve is innervating our heart. And so when the beat varies just a little bit, it's called sinus arrhythmia. We all have it. The more we're in just the sympathetic drive, it's completely regular, because not only does the heart rate increase, but it becomes super regular. And so we can measure that variability, and the more variable you are, the better it is for long-term prognosis. And all the research on stress and heart disease takes into account heart rate variability. But when it comes to seeing a patient in your clinic, you don't measure it, because you don't know what that heart rate variability was the day before. what was it over the month? Because you kind of have to, looking at one data point in isolation can be dangerous. And so it's looking at it at multiple data points. One of the things that I didn't get to, and one of our naturopathic doctors has a biofeedback clinic at the center. And we use the heart rate variability signal, and you can watch it on a computer. And then we give you exercises, very simple, like deep breathing, to see how that heart rate variability improves. And you can get apps on your phone and get a monitor that clips to your ear. So you can do this at home. If meditation's not your thing, you can do biofeedback. And that's been shown to improve heart rate variability, improve stress resiliency, and improve outcomes. And so the question was, having a family member go through an acute process and going to multiple doctors where they're all looking at that canopy and looking at different organs at a time. So who is supposed to look at everything comprehensively? And the answer she got from the nurse practitioner was the family doctor. So ideally, it is the primary care physician. And we are hoping that integrative medicine and this holistic thinking, some of you may be aware that the Samueli family gave $200 million to UCI to create this integrative health mission that's going to infuse our system. And so we just, in this last year, got a track approved for our medical students to, over time, have up to a third of them choose the integrative medicine track to teach this kind of thinking. Because this is about a shift in our framework. It's not just about, learning about stress or learning about nutrition. It's really about paying attention to the whole patient. But, just in defense of the conventional physicians, I'm lucky, I'm a researcher. I get to spend an hour with a patient at a time to get to some of these things. You can't jump into some of these issues in 15 minutes. And so our healthcare system needs to change. And, with the Samueli gift, I'm hoping that we're going to be able to demonstrate to the system that this kind of care leads to better outcomes and saves money in the long run. Because right now, the idea is this costs too much money and it doesn't pay. And, a growing number of us don't agree with that at all. So with that, I think, do we have more time?
One more question.
Okay. Yes.
I'm very interested in any answers
So,
for the clinical trial.
yeah. So the clinical trial, unfortunately, is for heart disease and diabetes, and we're doing chelation with EDTA because there was a signal there that you can drop heart attack risk by 30% if you do chelation for environmental toxins. Coming back to cancer care, and what do you do once you've successfully gone through chemo? What are some additional things? And so we do have a physician at our center, and there are integrative oncologists. There is the role of different supplements, chelation, and it can become part of sort of the chronic care to make sure that you prevent a recurrence. So there are providers that can talk to you in detail about that. And good luck. Congratulations for being done with chemo.
Thank you very much, Dr. Malik. And please acknowledge her. Thank you. Appreciate your being here.
One last thing, we have Alex Anderson in the back. She's going to raise her hand. From the Institute, we have a well-being circle where you can join and come to more lecture events and hikes and mindfulness events at the center. And then we have we have a conference, and what else did I forget? I don't know. Oh, Women's Wellness Day. So we have Susan Samueli started a conference at our center 17 years ago called Women's Wellness Day. And this year the focus is on aging. It's April 26th, and you can find out more information about it. We have speakers that will talk about an integrative approach to aging. Thank you so much.